Good evening, everyone, and welcome to TriVersity Talk. I am Stephen Bloomer-Teague.
And I am Wendy Stewart Kaplan, and thank you for joining us tonight, 7 o'clock, on a night so hot you could fry eggs in the street. How about that?
Oh, my goodness. I keep telling myself I'm going to appreciate every day of summer because of how miserable winter was this past year. But I'm getting to the point where I'm over it. I'm ready for 70s. I'm ready for pumpkin spice lattes.
My God, right? Pumpkin pie, all of that cool stuff.
Yes, absolutely. So
how is your week, Stephen? What's going on at TriVersity this week? We always have so much going on.
One thing we have going on is we have an event on September 12th, a farewell to summer meet and mingle. This is kind of an event that's pretty much designed for mixing with your friends, just getting a nice chance to talk, have some free wine and some hors d'oeuvres, and just get to know each other. And that's at the Phoenix in Dingman's Ferry. Again, it's on September 12th from 2 to 5 p.m. And if you want more information, go to TriVersityCenter.org.
Our fabulous website. And we have wonderful talent for that event. It's Dan Engelson, who, I hope I said that right. God,
I nailed it.
I nailed it. Dan, many of you have already heard his wonderful music. He's perfect for this event. My nickname for him, of course, is Dan the Sound Man.
Yes. Well, he will forever be known as Dan the Sound Man after he saved our tushies at that first talent show. So.
Oh my God, he just was the absolute best. So we are very excited tonight. Many of you tuned in a couple of weeks ago when we had Dr. Joshua Safer and Matthew Bainey from Mount Sinai Center for Transgender Medicine and Surgery. And they gave so much information that night and just really shared the nitty gritty of what it's like running a center, a complete center like that. Mount Sinai, of course, is located in New York. Tonight, keeping in the same vein that we were in, we are really thrilled by tonight's guests. We have tonight with us Dr. Bella Avanessian. I hope I said that right. Stephen, you pronounced it better than me.
I think, I've seen you butcher names before. That's pretty solid.
Okay, cool. She is the assistant professor of surgery and a board certified plastic surgeon. And then we have Dr. Jess Ting, who is the assistant professor of surgery at Mount Sinai. They have so much to share with us tonight about different procedures, what it's like. We're going to cover what people go through, including, with insurances. Everyone's always asking us about that. And we are really excited to hear what they have to say. So without further ado, come on in.
Welcome.
Welcome.
Hello. Hi there.
How is everybody this evening?
It's a little hot here in New York.
Yeah, right. Just a little bit hot. Oh my God, the scenery is going right past you, Jess, out there. This is quite the virtual background. I don't think we've ever had a virtual background like this.
Yeah, that's a pretty impressive green screen, isn't it? New York scenery.
Well, I would expect nothing less from Mount Sinai. Thank you both for being with us tonight. We love to jump right in, especially with a segment like this, and just talk about, Bella, I'd like to start with you. How did you end up taking the direction of this type of medicine?
Hey, Wendy, and thank you for having us on here, and you got my name right. So I was first exposed to the idea of underserved populations and transgender patients as a medical student in Providence, Rhode Island. And I had a family medicine friend who was focusing on working with the underserved populations. So I didn't think of the population again until I was actually in the middle of my plastic surgery training, also in Rhode Island. And I just had the thought, like, this would be interesting. I like the idea of working with the patients. I had heard that the only additional training it takes, in addition to plastic surgery training, is really an open mind.
Wow.
Yeah. So after thinking of it again, I went to some outpatient adult and children's clinics for transgender care. And I found that children and their parents' stories really, really compelling. And I knew I wanted to work with the population, but had never seen surgeries. So I traveled around to a number of places and saw the surgeries, saw how complex and interesting and creative they were, and wanted to get in. And I was lucky enough to find Jess. Jess invited me to train at Mount Sinai when I had been planned to train in Belgium. And I never thought about it again. I was very fortunate to find training right as I was graduating. And
the universe, baby, working its magic, you know?
Exactly.
Yeah, really. And I have to say, you just make it sound like so easy that, you know, you just really needed to have the commitment or awareness of it. But what I'm loving so much is a term you used a couple of times, wanting to serve the underserved community. What ticks in you that made you aware of that?
It's hard to say. I feel that I'm very fortunate in a lot of ways, and I don't take that for granted. And when I think of people, I think of all people as having a value, and no one is better than anyone else. And I don't know, something in me about that, and just knowing that I can approach things without judgment, I think makes me good at making people feel comfortable.
Well, bless you for everything that you just said. You know, in the world of plastic surgery, right? When we think about it, we think about the plastic surgeons that do the $25,000 facelifts and then are off on some exotic vacation. And that's a lot of people's impression of plastic surgery, right? I love that you have honed in this particular area. And to coin your phrase, yes, transgender people are underserved. They are being served more because of medical professionals like yourself and Jess. So thank you both for that. And yeah, as we all move forward, this is going to be, I call it a brave new world, because we're learning more and more about it. But to be helping people live their truth, to me, is everything. Now, Jess, I want to ask you the same question, because one of the things I read about you that was so interesting to me, you were studying music at Juilliard.
That's right. I was a classically trained double bass player and was at Juilliard for pre-college. I also got an undergraduate degree there and a graduate degree as well. And after I finished my master's degree, I decided that I would pursue medicine. You know, I want to add one thing about Bella. She's so humble. She was actually the first fellow in the United States to do a one-year fellowship in transgender surgery.
That's amazing.
And thank you for saying that, because I did read that in her background. And yes, Bella, you are humble. But when I meet people like you, one of the things that they're so incredibly humble, but so incredibly aware of what's needed out there. Jess, what made you go from, I mean, Juilliard is the creme de la creme. You could have done anything from Juilliard. What made you take this turn into medicine, particularly transgender medicine?
Right. Well, you know, I don't know. Do you ever take a taxi in New York? You ever been in a taxi?
All the time, yeah.
Well, chances are your taxi driver was a Juilliard graduate. So, having a degree from Juilliard is guarantee of maybe a life of unemployment. And, so it was very practical things. My brother was a surgeon. He's like, well, listen, Jess, do you have any auditions coming up this year? I'm like, no. He's like, well, what are you going to do? You know, there's this pre-med program at Columbia. Why don't you just take a couple of classes? And that was that. But to answer the second part of your question, I mean, we need to put things in perspective. It's 2021. In 2015, there were no surgical programs in New York.
Right.
Not one. There was no place that a trans person could go to get gender-affirming surgery. No insurance plans covered them. So if you were trans and maybe if you had the means, you could fly to Thailand and have surgery, pay out of pocket. But for the vast majority of trans people, there were no options. So in 2015, Governor Cuomo passed a law that insurance companies would cover transgender surgery in New York. But that still left us without any surgical programs, right? What good is an insurance coverage mandate if there are no programs where you can get surgery? And that was when Mount Sinai, the CEO, Ken Davis, the dean, Dennis Charney, and the hospital president, David Rich, decided that Mount Sinai would take the lead and start the program. And for me, I was just in the right place at the right time. It's not something I had ever thought about doing. I knew David Rich from our other prior interactions, and he just asked me, would I be interested in learning this surgery and helping them start a program?
Incredible. But again, you went to medical school. You could have been any kind of surgeon. Why in particular transgender surgery?
Well, for 20 years, I did general plastic surgery. I did a lot of breast reconstruction, and, I had a successful practice. I'd done well. It received, most of the accolades that a traditional medical student would aspire to. But for me, I always felt that maybe there would be a higher calling in medicine, serving the neediest. And I just saw this maybe as an opportunity to do that. And it absolutely was.
Serving the neediest, and Bella serving the underserved. So there you both are working together, which is quite incredible, making a difference in people's lives. So I want to talk with you both about your specialty areas. I'm sure some things overlap, and then there's probably some things that are unique. Bella, you want to go first about your area?
Sure. So we actually overlap quite a bit. I focus on facial feminization, chest feminization and masculinization, and mostly genital feminization. So many of my patients are trans women, and my trans masculine patients tend to be top surgeries, so chest reconstructions. And Jess?
Right, so I do some of the same surgeries as Dr. Avanessian, vaginoplasty, male to female bottom surgery. I also do female to male genital surgery in the form of ventilioplasty and phalloplasty.
Being that none of us know these terms or have only heard them maybe once or twice, can you go into detail what those procedures are?
Right, so I'll give you the 30-second mini course in phalloplasty. It's essentially taking parts of the body and using them to form the penis, the male anatomy, penis, scrotum, and urethra. And Bella can tell you about vaginoplasty. It's just the same thing, but in reverse.
Yeah, it's basically a disassembly of the male genital structures and a reassembly in a more fitting configuration that actually looks very natural and pretty and symmetrical and is fully functional.
So fully functional, but aren't there different, Simone Krause, who's our vice president, and will be on in the comments, but Simone explained to me there's a few different kinds of vaginoplasty.
Correct. Yeah, vaginoplasty.
Thank you. And that one is not all that functional. She, you know what? She uses this analogy of driving a car into a garage.
Okay.
Sometimes you can get the car all the way in, but there's, just like that. But sometimes the car won't go in just as far. Could you just, that's incredible analogy, but for a layperson like myself, it at least gives me a picture of what that is when I'm talking to people. Could you elaborate on that, please?
Sure. So I guess there are lots of different ways to classify it. By far the most common type of vaginoplasty is a penile inversion vaginoplasty. And usually most versions of the procedure involve that. It basically uses the skin envelope of the penile shaft as something that gets pulled down and inverted or like turned inside out from the beginning of the lining of the vaginal canal. And that is the basis for most current vaginoplasty techniques, regardless of if you call it, there are many intricacies, but there's peritoneum, there's peritoneal pull-through, there's skin only, there's rectosigmoid. There are lots of different confusing terms, but they all aim to accomplish the same thing, which is give natural appearing genitalia with a functional clitoris capable of erotic sensation and also orgasm, and a functional usable vaginal canal that has a depth that can stimulate the patient and accommodate a partner if needed. And when well healed, and most of them do end up being well healed, you end up with very nice functional genitalia.
Once they're well healed, there are probably things that happen. We know people that have had to have revisions because of, and then also I think it's up to the patient to use the dilators, follow the protocol that they're given by the doctor. Not everybody does. We know that. And then they often end up back for a revision.
So yes, there is a high degree of compliance that's needed to maintain what's said in surgery. So you can do a perfect surgery, and without proper aftercare, it won't amount to a successful result.
Well, that's incredible that so much depends on the aftercare.
So Bella, what would aftercare look like for a typical patient? Like how long can you not be on your feet after a surgery?
So every center does it a little differently. We like to get our patients on their feet again the day after surgery, just for light walking, maybe a few steps, maybe just standing at first, but the day after surgery. And then our patients typically stay in the hospital until they're 3 days out from surgery. And then we see them at 1 week and 2 weeks, and then a month if things are going well, and ongoing follow-up visits. For about 3 months, we like patients to take it pretty easy. For the first month, they're really offloading. It's a lot of vegging on the couch and a lot of assistance from family or caretakers and friends.
Are there drains and things like that?
So it depends on the surgeon. We all use little drains that aren't uncomfortable, but it's all under a vacuum device. It's basically like a wet, dry vacuum that acts as a splint or a cast over the surgical site. So it offers some protection. It sweeps away the gunk that is seeping out of the surgery site, and it also keeps things nice and caboodled away. So the patient only has to deal with this vacuum device and their urine catching bag, and the surgery site is protected for a week and everything's stabilized.
Wow. So how long is the vacuum's only on for a week?
Yep.
And then how long is the urine bag on for?
Same time. So after a week, we see them in the office. We take everything off and out because the vagina also has gauze packed into it.
There's a lot going on there. I'm like,
what's going on?
We got a bag, we've got gauze, we've got a vacuum. I didn't know about the vacuum.
Mm-hmm. And then the urine bag comes off, and that day the patient is largely normalized, and moments after everything is off and out, dilation begins. So we insert the dilator as the patient watches, and then we have them take it out and insert it on their own. So we do some teaching so they know what they're going to be doing from then onward.
And how often does a patient need to dilate? Like how many times a day?
We usually start, again, every place is different. We usually start twice a day and then quickly escalate to 3 times a day, where I encourage patients to stay for as long as they can tolerate it, ideally for close to a year. And then if they put a lot of effort into diligent dilation in the beginning, a lot of the time I find that it's easier for them and quicker for them to wean themselves down in frequency of dilating, but it's highly variable. So after about 2 years, I have patients that dilate once a day, and then I have patients that dilate once or twice a month. So
but even after 2 years, they have to still use the dilator.
It's hard to say. There's no long-term
getting that
research, but
some patients don't have to dilate. It depends on how often they're having sexual intercourse, depends on their particular anatomy. It really varies from patient to patient. And Wendy, you mentioned that you had never heard of a vac used before. That was another technique that we developed at Mount Sinai, which dramatically, you don't have to change bandages for a week.
Which is amazing considering
Dr. Ting developed.
Yeah.
Right.
Yes. So Jess innovated a lot when he was first introduced to vaginoplasty. Marci Bowers, who is like our goddess, and you're familiar with her. So she taught Jess vaginoplasty, and right after he learned it, he moved the incisions, which every surgeon had been putting like right in the middle of the labia, to off to the side to like a more hidden location. And then he and a patient developed peritoneal vaginoplasty, which sparked the whole trend. And now it's in vogue. It's available everywhere. Everyone.
I do. I read about that. Can you elaborate on that procedure in particular and why someone might prefer that to the regular vaginoplasty?
I'll let Jess talk.
Yeah. So you asked about the different varieties.
Yep.
Maybe within the first year after starting surgery, a patient came to me and brought me a paper that discussed in cis women with vaginal agenesis using these peritoneal flaps and flipping them down, and that peritoneum was really good for creating a vagina in women who were born without one because it was pink, it was hairless, it secretes fluid, and it's estrogen responsive. And, I said no initially, and I took that paper and I just was thinking about it. And a couple of weeks later, it occurred to me that maybe we could use the peritoneum, not as described in the paper, but as a free graft. And I found a laparoscopic surgeon, Mazen Iskandar, who was very gifted, and he agreed to try it. And we developed this technique, which had never been done elsewhere, and is now a standard part of our vaginoplasty operation. It provides, a variable amount of tissue, which is really very much similar to a cis vaginal mucosa lining.
So it allows the person more sensitivity than a basic vaginoplasty? Like what would make someone want to do that version of it?
Well, there are a couple of theoretical advantages as well as practical ones. Theoretically, this is graft, which we never had before. So it allows us to provide more lining. If you have more lining, you can maximize the depth, right? Creating a vagina is one thing, but you need tissue to line it. And if you don't have enough lining, it won't stay open. So having this new source of tissue provides that. But it also has advantages. Prior to that time, most vaginas were created with a scrotal skin graft, and we still use that, but using peritoneum in addition allows us to use less of scrotum. And scrotum, has hair. Even if you do hair removal, it's never 100% effective, and it's pretty common to a couple of years out and you do an internal exam to see some hairs growing.
Hairs growing in there, right? Wow.
Right. And the final thing is that this tissue is secretory, right? It lines the inner abdominal cavity of your body, which is always filled with fluid. The fluid like ascites, that fluid.
Right.
So, it provides some self-cleaning, some minimal lubrication. It's hairless, it's pink, and it also responds to estrogen.
It sounds like, pardon the pun, just what the doctor ordered, really.
Yeah, right.
Why would anyone want to do the other kind when is this got to do with your body structure, if you're good for this kind of vagina or not? What makes a person want to?
Well, I mean, this is still a relatively new procedure. We're in the process of publishing it. I think once we do publish it, it will become much more widely used. I've shared certain details of the technique with other surgeons, and I know many other surgeons. Just in this community, word of mouth is everything.
Of course.
And we've done probably 1,000 of these operations, so word is out in the community. It's something that patients seek out. And when patients seek it, other providers want to offer it. So it has very rapidly become a commonly asked for and commonly performed version of the operation.
Now I have a question, and hopefully I can phrase it as well as I can. Do you think transgender surgery gives a lot of room for pioneering techniques? I mean, is this so new that it gives the opportunity to, do what you did with this?
Yes, and it not only gives the opportunity to, it really requires it. It's a young field. The operations are young, and particularly in my opinion, on the female to male side, there's room for improvement. I think we will see that. We're already seeing it, and as this surgery becomes more widely performed, you'll see more and more advances. It's just like COVID, right? If COVID is everywhere, you start to see more mutations. If this surgery is everywhere, we will start to see more and more variations and innovations in techniques.
And this particular surgery, you said, has been around for 2 years now?
It's going on 3, maybe 4 years.
Okay, and you've performed it on about 1,000 patients.
I have to sit down and count, but we're up there in the high hundreds by now.
Right. And is Mount Sinai the only center where you can get this surgery?
I mean, I don't know. I just hear from word of mouth, other surgeons offering it. I don't know what version they are offering, or if they're just, using it as a marketing tool. It's not something that we actively marketed because I felt that it was still under development, and we always talk to patients about that, make sure they know. But, at this point, we've done so many that for us, it's, for me personally, I view it as the gold standard.
I love hearing this, Stephen.
And what I will say is, like, not to be here marketing, but if I was going to get a procedure like this, I would want to get it from the originator and not, from somewhere else. But, that's just me. So I have a question. You get this from the far right typically, and I think when Rand Paul was interviewing Rachel Levine, he made a comment, and what he talked about was that these surgeries are mutilating your bodies. And I'm sure that you two have encountered that line of argumentation. And I was just wondering, how do you address it if you hear somebody saying that these surgeries are mutilation?
Well, every surgery is mutilation. You do a facelift, a breast aug, abdominal surgery, colostomy, those are all modifying the body in some way. I view it differently. I view this as life-saving surgery. 45% of trans-identified people attempt suicide in their lifetime. That tells you something.
We talk about that all the time. Absolutely.
Right. I mean, I have to say, not every trans person wants surgery, and everybody's transition is different.
Yes.
But for that segment of the trans non-binary community that seeks surgery, it's life-saving.
That is completely agreed. And talking about this particular technique. Thank you for sharing that with us tonight, because Stephen, we had, with everything that we hear, we had not heard about that technique at all.
Absolutely. I mean, again,
right. When you share
I'm
it,
always learning on this show, and that's
Yeah,
why I
right?
like doing it. You know, it's
what are the downfalls to that particular technique? I'm sure it's got its challenges and complications.
You know, I don't really see any negatives to it.
And I think that as long as it's indicated, if you don't have sufficient tissue to line the vagina, then it's by far the best option, because you don't have to make any additional scars on the body. But if you do have sufficient tissues, we have an alternate technique that gives us slightly less tissue of the same type of tissue, but adds no additional risk to the body. It doesn't require an additional surgeon. It doesn't require additional access into the abdomen, and additional potential for even minor risk of complications.
Yeah, so what she's alluding to is that, you know what, we've evolved the operation, the use of peritoneum, and to the point where there really aren't any downsides that I can see.
I mean, that's just brilliant hearing this and getting this news out there for people. I mean, you did say something, Jess, and we've experienced this, and I have a few friends. Not everybody transitions their definition of transition. Some people will go the whole route, or as Julie Gray Owen says, they take the train all the way to Montauk. But then I personally was thinking about someone I knew today that is maybe going to get off somewhere in between, and that's good enough. I think what we're talking about here is something that is so highly personal, but at the end of the day, it's what makes a person feel healthy and whole. And that, if anything, is the goal, right? You talked about the suicide rates. We've discussed those before. It's really very difficult for people that don't know a lot about this world to wrap their head around the fact that somebody, their entire life just feels like, no, it's not right. I was not born right. I need to be what I feel I am inside. And that's a tough one. And we all try. I'm certainly trying to explain that to people all the time. And it just doesn't always go through the pain that somebody goes through, knowing that they have been misgendered from the time they were born. Now, you did hit on something that we haven't talked about a lot. And again, forgive my pronunciation, interstitial, or people that are born with
intersex.
Sex, thank you, or someone born without a vagina, or what kinds of things have you encountered with that? And my question is that considered transitioning? Where does that fall into this category?
Yeah, right. Very good question. Also, our definition of gender is evolving. It's not a binary thing. It's not male, female. There's a spectrum. And I think
Marjorie Taylor Greene was wrong.
Yeah, right. Exactly. And how people express gender is also a spectrum. Just like you said, Wendy, it could be something as simple as changing your name, changing your pronouns, your hair,
clothes,
the way you dress.
Yeah.
Intersex conditions apply the same techniques to them as well. I've treated patients with vaginal agenesis, congenital, and also as a result of surgery and cancer.
Okay.
Right. Vaginal agenesis is a person, a cis woman who was born without a vagina or with a very short vagina. And we can use these same techniques in that type of case.
But they are defined by themselves as a cisgender woman. That's how they identify.
In most cases of vaginal agenesis, I believe so, but that's not an ironclad rule. Intersex, people who are intersex, that's a very controversial topic. And in the old days, people who were intersex were basically assigned a gender by the surgeon. And
Looking at their
surgery by the line.
picking which way would be easier to convert the genitals to looking more natural.
But the problem is when that person grows up,
Right.
their own internal identity may not agree with what the surgeon decided for them.
That's my question, right? If your brain, and I hear this from people, your brain is telling you one thing, but your body is something else. But the surgeon at birth assigns you a gender based on what they're seeing, right? Let's call it your biological attributes. That goes into a whole other area. And that oh my God, that has to be so awful for somebody, you know?
Yeah.
We recently, someone called us at the center and they told us a story. A woman did 23andMe, did the DNA test, and found out that she has XY chromosomes. And this is an older woman. This had been kept from her entire life, and that she had a surgery that she didn't even know about.
Oh my gosh.
Yeah, for intersex folks, the struggle can be real. And I hope that that's beginning to change now. You know, again, you hear all these politicians talk about, you know, the dangers of surgeries with kids, but meanwhile, intersex infants or, you know, young folks are having surgeries that they don't even know about.
And can't consent to.
Yeah.
And that is very frowned upon in the intersex community, frowns upon the old treatment of operating on babies at birth or shortly thereafter. I recently saw a patient that had a surgery, and it was congruent with her XX chromosomes and her identified gender, but she feels that she has a very unnatural appearance. And in examining her, she looks very much like someone attempted a vaginoplasty, but maybe didn't perform it with the same finesse. So in her, replicating our same techniques is going to give her a much more natural result, which will hopefully increase her comfort with herself.
And make her a happier person. I mean, at the end of the day, you do this to have the result of a person feeling good and great about themselves and being happy. We have encountered, and I hear this, people that do the surgeries, right? Either male to female or female to male. And then afterward, they realize that was not the right thing to do. Have either of you experienced that with patients?
Not personally. I'll let Jess talk about it more because he's seen patients who have been detransitioning.
Detransitioning, yeah.
Yeah, I have not personally done any detransitioning surgeries. And, you know, fortunately, among my own patients, I haven't had a patient who has asked to detransition.
And me neither. And I know John Peng, our other partner, he also, nowhere within our practice has anyone asked to detransition. And we're at very many vaginoplasties and other gender-affirming surgeries. That's
right.
So again, in that 60 Minutes interview that's become rather infamous, one of the things was talking about was kind of like people wanting to detransition. But in your experience, now you're doing the surgeries, but in your experience, that just doesn't seem to happen. So
I've heard anecdotally of it happening. So, I mean, we see reports, so it must be out there.
But it's not a big thing. We've spent a lot of time talking about vaginas. I want to talk about, it seems to me creating a penis is very complicated. And with that, are there a few different techniques as they are with vaginoplasty? Oh my God, Siri's right behind me. She said, interesting question. I love to hear that. Oh my God.
That was hilarious, Siri. That's a great question. There are so many techniques.
So many techniques.
In plastic surgery, when you see so many techniques for one operation, you know that none of them is perfect. There wouldn't be that many.
Right. I have heard that after a certain amount of time with penis surgery, that they have to do revisions many years later.
Well, not even that. Just even to get a functional penis, it takes many operations over a period of a couple of years. Right. First you create the outside of the body, then you have to create like the glands, and you have to make the urethra function. And then you need something for erectile function.
So what is the time frame from your experience for such a complicated surgery?
At least a year.
At least a year of going in and fixing things. And then what happens after that year if it doesn't work? What are someone's options?
Well, there are also, this is an operation with extremely high rates of need for revisions. In particular, with the urethral system, it's fraught with complications, leaks, strictures, fistulas. Very, very hard, very difficult area of surgery.
Thank you for talking about that. It's good for in the world for people to hear this, because this word transitioning, a lot of people have no idea really the amount of pain, surgeries, and yet people do this because they need to do this so that they feel right about themselves. Female to male surgery, as you're outlining, is very complicated. Do you have, or have you seen 100% success rate with function?
Yes, but it's a long road to get there. It's absolutely not a walk in the park.
It's not a walk in the park. How many surgeries would you say? I'm sure it varies with people, but from your experience?
A minimum of 3.
Yeah, that's a lot.
At very least 3.
Wow.
And those are spaced usually at least 3 months apart, because you need to allow the swelling to come down enough for the tissues to normalize. And if someone has a complication or problem with the urethra, again, like Dr. Ting said, it's very, very common. If they have a complication, before you move to the next step, often you have to address that and, again, allow it to heal after you've let it heal to be able to do the addressing.
And even these erectile devices, they don't last forever. So they have to be replaced at some point.
How often would someone have to replace an erectile device?
I mean, it depends on how often it's used and what sort of tissues they have. But every few years, right? And it's so and they're mechanical devices. They break, they leak.
Right.
They can move out of position. They can get infected.
They can come out through the skin or try to.
So I think a big takeaway from this, if you are a layperson watching this, people do not do this for shits and giggles. This is very important. You just would not do this just for the hell of it. This is life-saving surgery. And so you just have to realize when somebody's going through this, they're doing it for a very important reason.
And further with like the genital mutilation comment before that we were addressing, if you don't allow people to do these surgeries and get safe and effective care, what you put people at risk for is they have so much dysphoria surrounding this body part, which in this case, whichever part you may choose, but so much dysphoria surrounding it. Sometimes people will resolve to self-mutilation, which is just atrocious and can kill someone.
Yeah, it can. You know, Bella, being that you brought that up, because we had chatted a little bit about that. I make films in remote parts of the world, and I spent time with the Maasai people, and I had the intention to do a short film about female mutilation, right? Which we had read about here. I think there was a very well-known model that called Like to Adhere, an African model that talked about it. And this is what really amazed me. So I had, of course, my Western view of of how awful that was and everything. And we found ourselves in a village where some of the women spoke English and the men spoke English. And one of the Maasai men, middle-aged man, when he started talking to us, he was trying to explain. He said, you know, you Westerners think it's so terrible what happens with the women, but it's part of our belief and our culture to do that, and everybody agrees on it. And I'm thinking, when I'm in a situation like that with such a different culture, a tribal person, you have to take your judgments and everything and put it out the window. And Lord knows I came there with all the judgments because I think it's horrific. So I hear him say that, and then we go into this village and we start talking to the women about it. And this is what really blew me away. They didn't think it was a bad thing. And Bella, you're talking about the infections and everything else. But if a culture is not, when someone is educated and comes here, right, from a different culture, but they've gone through an education, they get an awareness. That's what I'm trying to say. These women, it was more important to be part of their society, you understand? And they risk the infection, they risk the profuse bleeding. I mean, it's terrible what is done. And yet I couldn't continue on with the film because I really didn't know what to say from my perspective or what it was I was trying to show. Now, here in the United States, have you seen it from people from other countries?
Wendy, I've personally done 3 genital mutilation, female circumcision reversals.
Female circumcision, right. Coming of age, as they call it.
The first woman came to me because she was, I think, 40 and was about to get married and had undergone this procedure as a child.
In a foreign country?
Yes, in Africa, and could not have sex.
I know.
She was worried that, on her wedding night, she wouldn't be able to have sex. And what had been done to her was that her vagina had been sewed shut, except for a little tiny hole for menstrual flow to come out. The rest of it was sewed shut, and her clitoris had been amputated.
It's absolutely incredible.
And the way I asked her about it, and she said, well, the women are made to feel in this culture that they're not complete. They're not women, and that no man will desire them unless they have this done. So I think it's a matter of cultural indoctrination.
Absolutely.
But once she left that world and was in a Western society and began to question, well, why can't I have feeling in my clitoris? Why can't I experience an orgasm? And I talked to her about, she said, well, the thinking was that if women could obtain pleasure from sex, they would be promiscuous and unfaithful to their husbands. So the men saw it as saving the woman from having sexual urges. Well, you can't enjoy sex because then you're just not going to be faithful. So you know what? We're going to save you from that by amputating your clitoris.
Right. And you're going to be accepted in the society, which if their awareness hasn't been raised, that cultural acceptance is the most important thing to them.
Well, I can understand that, right? If that's your only world and you've been told this,
that's your only world.
You're a very young child. Well, when you turn 13, you're going to be a real woman. And until you have this done, no man will ever want you and you will be incomplete. So, well, I mean, who wouldn't believe that?
It's still a huge problem that's happening there, too.
I've heard it's also happening in the U.S. in some communities.
Yes, there are people still performing female circumcision here in the United States.
Wow.
I think that there are many variations of the operation. I've seen a couple that were less severe, so I'm hoping that maybe the ones that are done here are just very minimal, maybe almost like a ritual.
Wow.
Now, is it illegal in some states, or is it legal in every state? I
don't know the laws.
Yeah, I'd just be so curious on that front.
I would be shocked if it were legal anywhere, honestly, because I don't believe a physician or a surgeon is performing
Really?
procedures.
Yeah, but I mean, there are non-medical people who will perform male circumcisions, right? So
That is true.
I think that's completely analogous. And
Right.
doing
Right. There you
certain
go.
practices which may be unsanitary, stopping the blood flow with your mouth, which has spread infection in certain communities. In a male circumcision.
In a male circumcision.
Right. Well, I don't want to generate a whole bunch of hate mail, but that has happened.
No, I mean, we're just putting it all on the table here. I think these things have to be spoken about. If we don't do it, then I was unaware. I of course I know about male circumcision here, but I was really unaware that vaginal mutilation was happening here. Anyone I ever heard it from was from a foreign country. So I've learned something here today. I do want to talk with you about Kristen Beck, the Navy SEAL. Simone sent me something that Kristen transitioned, and this has got to do with what you were talking about, the facial surgeries, Bella, and how important they are. And they're really important because we can talk about everything that happens down below, right? But when you've got your clothes on, nobody's seeing that. Kristen wrote, "Oh my God, I'm out today to get a few things at Target. No one made fun of me. No jokes or foul comments. No one threw Bibles or rocks at me. No one called me sir. No one called me mister or him or any slang insults. I walked through the store, bought a couple of things with no issues, almost like a normal person, treated like a human." This is from a former Navy SEAL. Let's talk about facial feminizations and masculinizations. So, what are the challenges involved with those surgeries?
It really, they're very highly individualized. And just like that excerpt, it's tragic. You hear it and you just hear all the things that you take for granted that someone can only achieve after surgery. But what it does is, for some patients, their dysphoria is most pronounced because they're misgendered, or they personally feel completely incongruous with their identified gender and their appearance. And facial feminization helps with that. And it's not a cosmetic surgery. It's not cosmetic procedures. The goal is not to beautify. It's to feminize, and it's largely to just address the bothersome masculine aspects of a patient's facial features that bother that person, and cause that dysphoria, which is, again, the feeling that contributes to suicide rates and depression and just trouble going through the world and living in your own skin.
But I mean, even more than that, I mean, in this instance, it protects you from getting rocks and Bibles thrown at you. I mean, it's just your way to blend into society, even going past dysphoria. Question I have is, Jess, you talked about at the beginning that New York has a law that covers transgender surgeries. Are these surgeries that are considered part of that umbrella?
In the beginning, no, but I have a patient who sued, and she did get it covered. And the standards are changing, and more insurance companies are covering it with proper documentation.
Stephen, I'm really glad you asked that, because that brings us into that, slippery slope, right, of insurance and what gets paid for. So are insurance companies, from your estimation, now becoming more open-minded and seeing the facial surgeries in particular as something that it's just needed, totally and completely needed?
Yes, because we're not doing facelifts. We're reshaping the bones of the face. We're making the face congruent with the internal gender identity. Right? Nobody sees what's underneath your clothing, in your
That's right.
pants, but your face is what the whole world sees. It's how everyone interacts with you.
And the Adam's apple, being able to shave that down.
Yeah, these make big differences. If you identify as female and everyone out in the world is addressing you as male, that can't be a good feeling every day.
Right.
But also, as important as they are, and as much as they should be covered by insurance, and although the general trend overall is to be more inclusive for covering those cases, in some instances we see the opposite. Insurers that formerly used to cover those cases then perhaps do not, or they're introducing more obstacles to insurance approval or more restrictions in the procedures that will or will not be covered. So it's sad. It's just like trans teens are being robbed of the pubertal suppressants.
Oh, yeah, right. Puberty suppressants, yeah.
Which are completely reversible.
Right.
But they prevent the need to go through some of these surgeries.
Right. Terrible. Right. Right. You're absolutely right. I think with going forward with insurance, and I'm just asking your opinions on this, do you think, I mean, Bella, you just kind of said that as it gets more complicated, the insurances have more reasons to reject it. What do you think, say, going forward, because you've got a big center like Mount Sinai, and I have to think, and we talked with Dr. Matt Bainey and Dr. Joshua Safer about this, that there's other centers that are going to use you guys, pardon the pronoun, as a role model. How do you think the insurance companies are going to deal with all this going forward if this whole field blasts open?
It's really tough to say. I personally feel the surgery should be covered, and I think they should be universally covered.
I agree.
But not everyone is of the same opinion. Jess?
I think the insurance companies understand that it's better for society, it's better for patients. When they cover these medically necessary surgeries, their clients, right? They're a business, and these are their clients. Their clients live healthier, happier lives.
Right.
Even as a business, that's a good decision.
You're right. And maybe that's how it needs to be presented, that it's good business, right? At the end of the day, it's good business. Do you happen to know, either one of you, this isn't out there, but if legislation's being drafted to try and make more of this happen? Anybody working on
you
this?
know what? Legislation is built in. There is a legislation in the Affordable Care Act that says insurance companies cannot discriminate on the basis of gender. It's how that word gender was interpreted that kept changing from the Obama to the Trump administration. It was that interpretation of the word gender that was litigated, and whether gender also includes like your gender identity if you're a trans person.
Right.
So it was the legislation is there, the laws are there. It's it just comes down to the little details of how those words are interpreted.
Absolutely.
Lobbying.
Bella, what were you going to say? I'm sorry.
I was just going to say, but lobbying and advocacy are really necessary, and they're integral to pushing these things forward. And further, it would behoove the insurers to cover, or not the insurers even, it would behoove everyone to fully support the pubertal blockers, because if anything, the way to avoid needing to cover all of these surgeries and to minimize the need for some surgeries is to use pubertal blockers and then not have patients go through the undesired changes to their face and their chests.
Absolutely.
Genitalia, surgery is needed if someone is bothered, but those other two can be prevented.
Right. I think you brought out a good point. We did have an endocrinologist on here. You remember, Stephen, who talked about, yeah.
Yeah, that was actually a panel discussion we did about the Equality Act, which is a great place to plug the Equality Act right now, because you're talking about what's the definition of gender and would that include these types of surgeries? Well, you know how we could get that? If we have a law that says gender identity and sexual orientation. And that's why passing the Equality Act is extremely important to the LGBTQ plus community. This is just one example. But we don't have to fight these battles if gender identity is in the law itself.
Right. There you go. Stephen, do we have questions?
Let's see.
We always take questions. It's a part of the show where we take our questions.
Let's see. One question that Simone asked, and we're at the end of our time, but the difference between a vulvoplasty and a vaginoplasty. A vulvoplasty for someone who might be a late in life transitioner, who can't necessarily go through something as invasive as a vaginoplasty. I mean, yeah, what are your thoughts on a vulvoplasty?
I personally don't think vaginoplasty is much more invasive. And Jess, how old is the oldest patient that we did a vaginoplasty on?
77 at the time of surgery now.
Wow.
Wow.
And as she put it, you know what? She was in a 30-year marriage, very happy. And she's like, well, I'm doing this for me. I've wanted this since I was 5.
Wow. Her whole
never had the means to do it. And now that this is available, I'm doing it for me.
Incredible.
And I have a 74-year-old who recently had facial feminization, well, in the last 2 years, and she is getting ready for her vaginoplasty.
So it's never too late.
No. And the risk is not much greater with vaginoplasty. I think as long as someone is healthy and dedicated to postoperative care and can cooperate with that, there's not much difference. But a vulvoplasty is just creating the external genitalia without the canal. Sometimes the canal helps set the aesthetic, but it's not absolutely necessary. But I don't think age should be a determinant.
Right. So if you're speaking, I guess vulvoplasty is the same as zero depth vaginoplasty. Mm-hmm. Yeah, I don't really. We do vaginoplasties, regular ones, so quickly and efficiently with low side effects.
Super low.
It takes us 2.5 to 3 hours to do a vaginoplasty.
From the
well. And you know what? Making a zero depth vaginal, that is like a permanent decision. It's very hard to go back later and create that vaginal canal.
You wouldn't have the sensitivity from a vulvoplasty, right, that you have with a vaginoplasty.
The sensitivity is pretty much the same, but you don't create the canal. And we've then removed all the tissue that we would use to create the canal. It becomes a much more difficult proposition to do it.
To do the vaginoplasty after, if a person wants it.
And prostate stimulation does happen through the vaginal canal or anally. So in that sense, maybe less sensitivity, but the clitoral erogenous sensation should still be there with a vulvoplasty, depending again on who's doing it and if they're staying true to the techniques.
Well, thank you for that. Well,
thank you. Wait, I have one question. One last question. I know we got to go. So this is my question. I knew someone that transitioned from female to male and then eventually had to have the uterus surgery. Could you just quickly talk about the risks of cancer?
Well, if you take the uterus out, no risk of cancer in that anymore. Right. But in terms of breast cancer or prostate cancer, which are the two organs, breast cancer, it's not really well studied. If someone's been on hormones for more than 20 years or has a family history of breast cancer, they should have mammograms or other imaging. And everyone should follow the screenings for natal females with breast cancer, in my opinion, based on like age and family history. And then prostate cancer, low risk for people who are on androgen suppressors.
Or who have had surgery.
Or who've had surgery. So
extremely low risk because there's no testosterone. For female to male patients who either undergo a partial mastectomy or an oophorectomy, the risk of breast cancer is going to be lower because there's no estrogen.
But not impossible. So
not impossible, but lower.
Oh my gosh. Thank you both so much. We're going to say goodbye, but just hang out after. So I always take a picture of our guests. Okay. So we'll say goodnight to our audience.
Yes. So thank you, Jess. Thank you, Bella. This has been wonderful. Like I say, when we have these interviews, I learn so much, and that allows me to be a better leader of the center. So I greatly appreciate both of you.
Allows me to be a better advocate because I'm the person that everybody asks the questions of, including
Thanks for having us.
Need direction. Thank
you.
you very much.
An honor to be on the show. Thank you.
Thank you so
Very
much.
much. Thank you for the invitation.
Yes, and good night, everyone.
Good night, everybody.
We will see you next week.
Next week.
Bye-bye.